Hello, my name is David Trimberger, and this is attempt number 3 at peer-to-peer for intubation. First thing that I want to do is gather up all my materials to make sure that I have proper PPE. I have a properly fitting laryngoscope that works. Check it one more time. Okay, see that the light works. I also want to make sure that I have a properly fitting ET tube. So this one is currently an 8, which would be used more for your larger patients, but for your average adult, you want to use about a 6.5 to 7, and then pediatrics is going to be significantly smaller based upon your patient. I also want to make sure that I have capnography, my rigid and flexible suction devices, as well as BVM and oxygen. First thing, after I've gathered up all my materials, apply proper PPE. And then for my patient, I'm going ahead and I have them on a high flow nasal cannula. And then I'm going to come over, inspect their airway. If I see any secretions, then I'm going to go ahead and get rid of all the secretions for suction for no longer than 10 seconds, going in a zigzag motion on my way out. Re-inspect the airway. If I see that all the secretions are clear, then I'm going to measure my OPA, insert my OPA. I'm going to come over and also connect my BVM to oxygen and my connect an SpO2 monitor to my patient. Ventilate my patient at a rate of 10 to 12 times a minute. Going to be monitoring for adequate chest rise and fall, and then once my SpO2 gets above 94%, my patient has had enough time to become pre-oxygenated. I'm going to go ahead, remove the OPA, going to come over in my non-dominant hand, hold my laryngoscope, going to come over and place my patient in a sniffing position, re-inspect the airway, going to displace the tongue, lift up the mandible, there we go. Now I can see. Place my ET tube, fill up my balloon, remove my syringe, remove my laryngoscope, and then I will come over and remove my stylet. And then I will ventilate my patient, make sure that I can see adequate chest rise and fall. And then I can also auscultate over my lungs as well as the epigastrum to make sure that I have proper placement. And then I will adjust the tube accordingly if need be. Once that I have confirmed proper placement, I will attach capnography or secondary confirmation device, connect it to my monitor, and then continue to ventilate my patient and note for any signs of hypoxia. Once that this is noted, I will go ahead and stabilize my ET tube, and then I will continue to ventilate at a rate of 10 to 12 times a minute, monitor my patient for any changes in patient condition. And then for the sake of the rest of the skills, say that I begin to start seeing secretions or other things begin to build up in the ET tube, I'm going to be using my stylet as a flexible suction catheter. So what I would do is make sure that my port is open. I will then insert the suction device in the ET tube, close it, allow for suctioning to be able to begin, and then slowly remove, and then reassess for proper tube placement, continue to ventilate my patient at a rate of 10 to 12 times a minute, evaluate for capnography as well as their SpO2 monitor, and then evaluate for any changes in patient condition. Thank you.